Okay, so we'll start again. So it's a 4-year-old boy who was transferred from his local hospital for an investigation for an unsteady gait and a change of behavior, fluctuating lethargy and sleepiness. History of present illness. This child had a few days of an unsteady gait. He had a generalized pain. He was holding his head, complaining that he wants a new head. And he had 3 episodes of vomiting 2 weeks ago. Before that, he had periods of fluctuating sleepiness and forgetfulness. That was for around 4 weeks. And a week prior to that, there was a viral illness. So this one, it all started where he had a sore throat and a low-grade fever. When we asked about some of his symptoms, he also has occasional reluctance to pass urine, but he was still able to pass urine. He was just retaining it a bit more. On examination, he was cooperative, a bit miserable, but was very subdued and sleepy. He had decreased mobility. It was mainly due to weakness and pain, and he was needing support from his mom to be able to stand and take a few steps. On examination, there was reduced power. It was around 4 out of 5 because he still had anti-gravity movements in his limbs. There were no signs of lateralization. And he had clonus bilaterally, and we could feel there's an increased tone in his gastrocnemius muscle. When we tested his reflexes, they were brisk in his lower limbs, and he had an extensor plantar response. With coordination testing, he had some pass pointing and incoordination, mainly of his lower limbs. The investigations that we got from his local hospital are remarkable. So his bloods were pretty much normal. He had a slightly high white cell count, but his CRP and the rest of his electrolytes were normal. His CT scan showed a hypodense area around 2 centimeters on the left suprasylvian area, and that was pretty much what he had. And he was mainly transferred for continuing investigations. So at that point, we thought it could be meningoencephalitis, an infective cause. It could be an acute disseminating encephalomyelitis, something that would affect his brain and his spine. We thought about vasculitic changes, and much rarely an acute necrotizing encephalopathy of childhood, like a post-viral thing. This is mainly in cases in East Asia, but there are sporadic cases all over the world where you get a viral infection, whether respiratory or gastrointestinal, and then you have secondary necrotizing changes in the brain. So the initial management, when he was first transferred, he was started on triple therapy, so ceftriaxone, acyclovir, and clindamycin to cover for meningoencephalitis. And then we started him on gabapentin because he had a lot of pain and his neck was quite stiff. He was very reluctant to move it, so we thought he might be having some neuropathic pain. So we started him on a low dose of gabapentin. And then we did the MRI brain and spine and lumbar puncture. That was done under general anesthesia. And there were patchy bihemispheric changes, mainly in the white matter with some involvement of the gray matter. I have actually his actual images. So as you can see on the MRI, those bilateral bright white changes. So increased signal on both sides, mainly affecting the white matter. And we also had some perispinal enhancement in the spine, as you can see by this white swollen part here. So it was a diffuse changes in the brain and the spine and a diffuse encephalomyelitic change. His lumbar puncture didn't reflect a lot of changes, so he had a normal cell count, and after 48 hours, there were negative cultures. The CSF virology was also normal. We also sent some oligoclonal bands, but they're not back yet, and I will explain why a bit later when we talk more about the details of the case. Because his cerebrospinal fluid was normal, we stopped all his antiviral and antimicrobials, and we thought at this point our differential changes. We are now thinking of an acute disseminating encephalomyelitis. So we started him on a high-dose pulse steroid therapy, IV methylprednisolone for 3 days, obviously with gastroprotection on omeprazole. And this was followed by oral prednisolone. We were going to continue this as 2 weeks, and we sent him home on oral prednisolone to follow up on discharge. We increased the gabapentin during his admission because he was still in quite a lot of pain, so to help his neuropathic pain. We also did a pre and post-micturition bladder scan because there was involvement of the spine to check why he was reluctant to pass urine, but all the results were normal. He had a normal void, no urinary retention, and a normal ultrasound. Because he presented initially with fever, we did do a COVID-19 swab, but that was negative. And we sent some specific antibodies, myelin oligodendrocyte, aquaporin 4, and MDRA to look for other specific autoimmune conditions that can also present in this way, and also because they give us an idea about prognosis. And then we had an input from physiotherapists and occupational therapists to help his mobility. He was sent home for follow-up. And I put the slides because I didn't know what the MOG antibody does. So the myelin oligodendrocyte glycoprotein in acute disseminated encephalomyelitis, it gives us, when they have positive antibodies, it actually has a favorable outcome. And then MOG negative acute disseminated encephalomyelitis patients in terms of like relapsing courses or recurrence. So it's quite helpful for that. So a few slides about what is acute disseminated encephalomyelitis, and then we'll have our 3-question quiz. So acute disseminated encephalomyelitis, it's 3 things: immune-mediated, it's an inflammatory process, and it's a demyelinating condition. It predominantly affects the white matter of the brain and the spinal cord, but there are sometimes certain affection of the deep gray matter as well. And it occurs more commonly in the winter months. I tried to look for a good slide for pathogenesis. I really didn't find one, but I'll try to explain it simply as I understood it. So we said it's an immune-mediated, it's an immediate inflammatory process. So it's a patchy affection of the myelin, which is the orange covering of the neuron or the nerve. But there is an axon preservation. So the axon cylinders are normally preserved in this process. And then in some susceptible individuals, there's an immunological change, mainly through the T helper cells. And the T helper cells are sensitized to antigens in the myelin sheath, and so attacks the myelin by producing autoantibodies against the myelin proteins. And in acute disseminated encephalomyelitis, they are mainly IgG antibodies. And this kind of triggers this inflammation or inflammatory cascade through the release of cytokines and interleukins and other inflammatory mediators, and thus we have this picture. There are normally a preceding infectious illness, sometimes an immunization prior to the occurrence of acute disseminated encephalomyelitis, but this is absent in a quarter of the patients. They normally have systemic symptoms such as fever, headaches, and back pain, and our child did have most of those symptoms. And the main thing is that it's an acute onset encephalopathy. But it's an encephalopathy that we can't put it due to the fever. It's not due to a post-ictal state or a fever because they can present with seizures. So it's mainly a behavioral or a mental status change. So encephalopathic child, basically. Most cases are rapidly progressive. They occur within hours and days, and in some cases can stay up to 4 weeks. Acute disseminated encephalomyelitis occurs mainly in younger children, so younger than 11 years. And I'm saying this because because ADEM sometimes, if it becomes recurrent, and I'll explain this a little bit later, we can think of conditions in older children, such as multiple sclerosis. On examination, it's actually quite important when we examine children with acute disseminated encephalomyelitis. They will have upper motor neuron changes. So if they present quite early, there could be, for the first few days, a loss of reflexes. We call it the spinal shock. And then that evolves within a few days to long track signs. So you would have brisk increased reflexes, you could have an increased tone, and you can have clonus. And in this child, he did have brisk reflexes and clonus. And obviously they do present with weakness, and the weakness can be of many forms. It could be a hemiparesis, it could be a diaphoretic change, or a generalized and symmetric change. Sometimes there are cranial nerve abnormalities, and sometimes there is an acute disseminated encephalomyelitis related transverse myelitis, where you have an infection of a certain part of the combine with the sensory level. And in those children, they can also have associated abnormalities of their bowel and bladder function. So it's important to ask this in our history. There are other presentations for ADEM that could happen in continuity with ADEM. For example, they can present with bilateral affection of their optic nerve, like optic neuritis. In those cases, we would have to do an MRI brain and spine to check there are no other changes there. Management is high-dose steroids, as we gave in our child, so methylprednisolone, maximum of 1 gram a day for 3 to 5 days. And then we give them oral steroids. Normally we would say 4 to 6 weeks, but we usually follow them up in 2 weeks and see how they were doing. We will need follow-up with the neurology team and the MDT therapy team, and sometimes we involve urology and gastroenterology if there is affection of the bladder and bowel function. Patients who relapse during the gradual wean of steroids, we would put them on we restore them, put them on the higher medication dose where they were controlled at that point, and then we do another slower wean. I put this slide because it's quite interesting about the similarities between acute disseminated encephalomyelitis and multiple sclerosis. The main two differences between those two illnesses, because they're quite similar in the way they happen and in the imaging as well as the presentation. In acute disseminated encephalomyelitis, it's normally a rapid onset and it's a monophasic disease. But in multiple sclerosis, it's chronic, it's relapsing and remitting. So we get repeated episodes over a long period of time. Acute disseminated encephalomyelitis occurs in prepubertal children. In multiple sclerosis, it's in postpubertal children. In ADEM, there's usually a clear predisposing factor or a febrile prodrome, but there's no prodrome in MS. And in ADEM, there's a rare presentation of posterior column abnormalities, such as a reduction in the vibration sense of position, stereognosis, but those are quite common in multiple sclerosis. In a minority of cases in ADEM, we have, sometimes you'd have 1 to 2 recurrences. That's why we have to keep a close follow-up on those children, but then they recover. But in multiple sclerosis, it's a permanent immune dysregulation, and they continue to have a relapsing and remitting disease. Does anyone, it feels a bit funny because I feel like I'm talking to myself. So does anyone have any questions? I'm trying to open the chat and see. Any questions, everyone? Or is it common? No, it's not common. It's not a very common disease. It's rare, but it does happen. Are you more at risk of developing MS if you have ADEM? Not necessarily. As I said, it's normally a monophasic disease. It occurs once. Very rarely, it can have some recurrences, but what's recorded in papers is 1 or 2 recurrences. But if you have a child with ADEM, you have to have a close follow-up to make sure they don't continue to have this chronic relapsing illness, and then we can start thinking of MS because they're both immune mediated. Is the dose of steroids the same in both conditions? I'm sorry, which both conditions? Whoever asked the question. Oh gosh, there's so many questions. Let me just take them one by one. So normally the dose of steroids, as I mentioned in the prior slides, is 30 milligrams per kg. The maximum is 1 gram per day, and we give it as a pulse steroid. Methylprednisolone is given as pulse steroid therapy for 3 to 5 days. Any ideas about pubertal relationship? I don't know that, but actually to write this question, I can look it up and send it later. What's the prognosis? They normally recover, so it's normally a good prognosis. Sometimes we do the autoantibodies, as I said, like the myelin oligodendrocyte antibody. When it is negative, it gives you an idea of a more favorable prognosis, like a single episode and a good remission. So normally they recover, but they will need therapy inputs for a few weeks. Is it associated with specific organisms? Yes, there's actually a whole list of causes. They could be associated with EBV, cytomegalovirus, vaccinations, especially measles. Measles, that was before this a good immunization program. Oh gosh, I'm kicking you up with all questions. Is the usual pattern to have a mixed neuro examination, hypertonic and weakness? So no. So initially you have the spinal shock where you have, well, you always have weakness because you do have an upper motor neural lesion, so it's affecting your mobility, it's affecting your function, but it's about your reflexes. So initially you would have no reflexes, you won't be able to elicit reflexes. It's called the spinal shock or the initial presentation, but it's a very short period that takes a few days, and then you start having the evolving long track signs where you would have spasticity, where you'd have clonus, where you'd have brisk reflexes, but they're all associated with weakness because there is a brain and a spine insult. Is there a role for IVIG in acute disseminating pneumonitis? Yes, there is. And in some children, actually, people, before they get the diagnosis, they can start giving IVIG. So methylprednisolone is the first line of treatment. But IVIG, because you can also give IVIG in severe sepsis or in conditions, it could be helpful in severe sepsis. So if we're thinking still about the differential of an infective cause, but it could also be an autoimmune cause, IVIG can help both. But the mainstay is methylprednisolone. I've seen a child with fulminant necrotizing encephalopathy following influenza. It was a quite similar case to the case he presented. What's the difference between this one and acute disseminated encephalomyelitis? So actually, fulminant necrotizing encephalopathy is a rare condition because, as I said, it's presents mainly in Asian countries like Japan and Korea, but there are sporadic cases everywhere else, and it is quite common to present secondary to influenza. I think with acute disseminating encephalomyelitis, the main thing, as I said, is the clinical presentation that we talked about, and also the MRI and spine changes. You have those patchy changes, mainly affecting the white matter of the brain and the spinal cord, and sometimes can affect the deep gray matter. So it has a very specific imaging and clinical presentation together. Is the dose of steroids the same in both ADEM and MS? I don't know about the dose of steroids in MS, but can I also look that up? Would you routinely repeat the MRI to check for resolution? No, not necessarily, unless they are worsening. We normally just keep like a close follow-up, and we can do an MRI repeat later. Okay, we'll move to our quiz, our 3-question quiz, and then we will continue the questions a little bit later. So I'll give you a few seconds. They're quite easy. It's pretty much what we discussed, just like the main points. So we would, I hope you can all see my screen. So what describes acute disseminated encephalomyelitis? It always occurs because of a primary autoimmune response. It's an autoimmune vasculitis of the central nervous system. It's a homogeneous, demyelinating inflammatory process of the CNS that is characteristically recurrent. And it's a patchy demyelinating inflammatory process affecting the CNS and often a single occurrence. So I'll give you a few seconds before we... Okay, so answer is, you're correct, it's 4. So it's a patchy demyelinating inflammatory process affecting the CNS, and it's often of a single occurrence. Because we said it mainly occurs, number one, it mainly occurs because of a trigger, like in most of the cases, 75% will have an immunization trigger or an infectious cause. It is not a vasculitic change. It is not homogeneous. It's more of a patchy changes in the brain, and it's characteristically a single occurrence. Very rarely you could have 1 or 2 recurrences, and those are the children we keep a close eye on to see if they will develop MS or not. Presentation of acute disseminated encephalomyelitis. There are prominence of cortical signs such as mental status changes and seizures. occurs more commonly in summer months. It's a slow onset encephalopathy. It's the neurological manifestation onset occurs within the prodrome. Any answers before I tell you the answer? Yes, so it is prominence of cortical signs such as mental status changes and seizures. So the main thing of acute ischemic encephalomyelitis is that you have an acute encephalopathy. It's a rapid onset acute encephalopathy that is not related, as I said, just to the fever or post-ictal state. It's more common in the winter. And I didn't discuss point 4, so that was a trick question. I didn't discuss it in my clinical picture, but normally, as we said, because ADEM presents in a typical clinical presentation as well as imaging findings, that you would have a resolution of the prodrome before the development of the neurological symptoms. They say minimum a day, but that could be up to 2 to 8 days, where you'd have a resolving of a prodrome and then the onset of the neurological symptoms afterwards, so they don't occur together. The last question before we move to our second case: treatment of acute disseminated encephalomyelitis. There's no treatment, it's supportive. IV methylprednisolone as pulse therapy for 3 to 5 days. Exchange transfusion is a first-line treatment. IV antibiotics should be given for at least 7 days. That's an easy question. Yes, that is correct. So IV methylprednisolone is pulse therapy. As I said, we do give IVIG, but that's our first-line therapy. So we do have a treatment. We don't usually give exchange transfusion as first line. IV antibiotics are justified initially till we get our diagnosis. We don't necessarily have to give it for 7 days. When our culture results come back, as they did in our child, we stop them after 48 hours. Perfect. So case number 2. So this is a child that we actually saw in the emergency department around a month ago. And this child had was not able to see with her right eye. And this was a gradual thing over the past 9 days. So history of present illness. This child symptoms started 9 days ago and they were gradually worsening. So she was complaining of some blurred vision. She was complaining of painful eye movements. She said a 5 out of 10 pain score. There were no systemic symptoms, so no headache, no vomiting, no other symptoms at all, and she had a normal bladder and bowel function. In her background, she was previously fit and well. She was fully immunized. There's no travel history, no contact with animals or deer, and her mom and her sister have a history of migraines, but no other autoimmune conditions. And her father reportedly had some visual problems a few weeks ago, needing steroids, but mom and our child didn't really, well, she's a young lady, not a child, but they didn't give me more details about this. On examination, she essentially had a normal neurological examination. So, So her Glasgow Coma scale was 15 out of 15. She was answering questions appropriately. She had a normal power in her upper limbs and lower limbs with easy listed and symmetrical reflexes. She had a downward plantar response and her spinal examination was normal. She had some intention tremors bilaterally, but that was more with her hands, and I think it was because of her vision. She had normal coordination otherwise and a negative Romberg and normal sensation. So essentially a normal neurological examination. And then we come to our cranial nerves. So when we assessed cranial nerve 2, she had a loss of vision of her right eye. So she really couldn't see anything with some perception of light.
No, we can't see your slides. They've disappeared. Oh, sorry to have interrupted.
Oh, no, thank you for letting me know. What happened? Okay, we are trying to fix this. So you can't see any of it at all?
No.
No. Yeah, it appeared all of a sudden.
Okay, sorry. I'm not sure what happened, but. Okay. I'm not sure how to fix it. Okay, just give me 1 second. File. Yeah, I think I know now. Screen, there we go. Can you see it now?
Yeah.
Great, perfect. Okay, sorry, so let me just briefly go through this again. So 15-year-old girl attending ED with loss of vision in her right eye, gradual over the past 9 days. So the symptoms started, as I said, 9 days ago. She had some painful eye movements and a blurred vision. And then today she woke up and she couldn't see at all with her right eye. No other systemic symptoms and previously fit and well. Her mom and her sister have a history of migraines, but no other autoimmune conditions. And her father had some visual problems needing steroids a few weeks ago, but we didn't have more information about this. On examination, she had a normal neurological examination. She had a bit of past pointing with her hands, but we thought it was because she couldn't really see well with her right eye, but nothing else on the primary neurological examination. Except for her cranial nerves, obviously cranial nerve 2, she had loss of vision of her right eye. She had some perception of light, but nothing else. And when testing her 3rd and 4th and 6th cranial nerves controlling her eye movements, she did have normal eye movements, no nystagmus, but she was complaining that it was painful. And she had a right-sided ptosis, but apparently that was long-standing, and we saw previous pictures of her where she had this right-sided ptosis basically since birth. So we sent a lot of investigations, her baseline bloods, some basal metabolic testing that were all normal. We sent virology PCRs for herpes virus, cytomegalovirus, EBV, Lyme's disease, everything was normal. We did some testing for an ASOT and anti-DNase-B that were normal for strep. She had a lupus screen that was normal and also autoantibodies that were all normal. We also did some other testing, autoimmune antibodies, like I discussed in acute disseminating encephalomyelitis. So we did MOG antibodies and we did an aquaform 4 antibody. Aquaform 4 antibody was negative and MOG antibody was a low positive. As I said, they give us an idea of prognosis and other associated conditions, which I will discuss later. And then we did an MRI for her brain and for her orbits. So there was a marked swelling and signal change in the retrobulbar right optic nerve, and this is actually her MRI. So you could see, not sure if you can see my pointing, but this, so the right side is going to be the left side of your screen. So this is a normal optic nerve here on the left, and on the right, you can see it's hazy and grayish and a lot more swollen. And in this other image, here you have a straight black line like the optic nerve, and here you can hardly see on the right side this straight black line. It looks, there's a signal change and there is swelling as well. This is not her fundus examination, but I thought it was a good slide to explain it. When we had an ophthalmology review on her right eye, she had an optic disc swelling, and normally if you have an optic disc swelling, you see a very blurred image of the optic disc as well as the vessels. And normally it would appear very clearly. You would have not a blurred image of a disc, and you would clearly see the vessels as well. So this is what we would see when we have optic disc swelling or edema. So our impression that this was an optic neuritis for investigation. Is it isolated? I mean, for investigation, is it an isolated thing? Is it associated with something else or not? So we started her on pulse steroid therapy. So methylprednisolone for 3 days with gastroprotection, and then she was started on oral prednisolone to continue till all the antibody results come back. Obviously, when we give high-dose steroids, I didn't mention this in the first case, but we always have to monitor blood glucose, urine testing, and monitoring blood pressure. We sent her home. When after that, we followed up with a telephone consultation after 3 days post IV methylprednisolone. There was some improvement in her vision. She could now see some objects, but they were more like grayed out, and she can also see red and green, but not other colors. So a few slides about optic neuritis before we start our quiz. So optic neuritis is also an immune-mediated process. You have a subacute loss of vision. This occurs within a few days and up to 2 to 3 weeks. In 85%, there's predisposing factor, as I said, an infection or an immunization. So similar to the things we were mentioning in ADEM. So it's an immune-mediated. It can also be a separate presentation, so a presentation of acute disseminated encephalomyelitis, and that's why we do brain imaging. Or it could be a beginning of a presentation of multiple sclerosis, and then you have this remitting, relapsing illness. Or it could be as part of another autoimmune condition called neuromyelitis optica, where you would have optic neuritis, but you also have spinal affection, and that's why we tested for the antibody called aquaporin 4, which is positive in those cases. It could be idiopathic, so isolated, never happens again. And it could be secondary to a vasculitic change, as in children with systemic lupus or a Lyme disease. And there are many, many other causes. I just put the common ones or the ones that were related to the presentation. So what did this girl have? The main thing I want to say when we test for optic neuritis is that obviously they have a loss of visual acuity, but that is not the most specific thing. The most specific thing is a change in their color perception. It's the most sensitive indication of an optic nerve injury. So if we have earlier cases, because we don't always test for color vision, I thought that was quite interesting. So the earlier the presentation, they have a change in their color perception, and then they lose their visual acuity. They have a change in their brightness sense, and they can also lose portions of the visual field. We couldn't really test visual field. Girl we saw in A&E because she completely lost vision. She couldn't see anything with her right eye. It was just completely black. But maybe in other cases when they wouldn't be as severe, we could be able to do the other things. In some cases, the ones that are not idiopathic or that are part of another autoimmune mediated process, as we said, as ADEM or MS, they would have ongoing neurological symptoms. And that is why when we have a presentation of optic neuritis, we do a lot of like antibody testing. We examine them very well. We do brain imaging to make sure it's not part of another presentation. And we also need to do very strict follow-up. Treatment, we usually give them pulse steroid therapy for 3 to 5 days, so similar to what we did in ADEM. And the prognosis is quite good. So they normally have a good visual recovery. That's in 70 to 85% of children. And we also do, as I said, really, really important follow-up with the neurology and ophthalmology teams. So we will start our 3-question quiz because we're kind of, oh, sorry, not yet. We're starting it after the slide. So I want to differentiate between optic neuritis presenting in younger children and older children. This young woman that we saw was 15. She was older than 10. And in older children, it's normally presenting unilaterally, so one side. When we did her imaging, she had affection of the retrobulbar part of the optic nerve. So it's normally a retrobulbar affection and commonly presents with pain on eye movements. And it's commonly idiopathic, like an isolated presentation, and they normally recover. But there's a high probability of recurrent demyelinating events, and that's why we need to keep a close follow-up on her and other children that present the same. Children less than 10, so younger children, it's normally bilateral. It's a papillitis. Papillitis means it affects the optic disc, so there's an optic disc swelling, not the retrobulbar part of the nerve. Commonly presents with other systemic symptoms such as headaches, and it's not idiopathic. It's more normally a post-infectious or a post-immunization, and there's a low probability of recurrence or demyelinating events in the CNS. But we still have to follow up both groups to see which category they fall into. Okay, let's start our 3-question quiz. So, what clinical history findings are characteristic of childhood optic neuritis? Periorbital pain that gets better with eye movements. Prognosis of visual recovery is generally poor. Subacute loss of vision, acute loss of vision. Yes, that is correct. That's quite easy, a lot easier than the previous quiz. So it's a subacute loss of vision over 2 to 3 weeks, not an acute one. We said the prognosis is quite good, up to 85%. They recover their vision. And the periorbital pain actually always gets worse with eye movements, not better. So when you move your eye, it hurts more. Question 2. In a workup of a childhood optic neuritis, MRI brain is unnecessary as it's more of a clinical diagnosis. CSF may show a lymphocytic pleocytosis. Neuromyelitis optica antibodies, which are aquaporin 4 and MOG, are always positive. CT scan is the investigation of choice.
Okay.
Perfect. So I didn't mention that, but it's probably by exclusion. So MRI brain is actually necessary to make sure there are no other associated conditions. Neuromyelitis optica is a condition that can present with optic neuritis, but you have an association of spinal changes, and normally you'd have aquaporin 4 positive antibodies, but they're not always positive, only if it's part of that condition. And CT scan is not the investigation of choice. If we do CSF, we didn't do a CSF in this trial, but if we need to do a CSF in children where diagnosis is not as clear, they can show an increase in lymphocytic counts and lymphocyte pleocytosis. Last question: treatment of optic neuritis. Oh, sorry, that's wrong. Optic neuritis. No treatment can alter the duration of illness, and it's always an isolated illness. Aspirin is a treatment of choice. It's given in high doses. Pulse steroid therapy is a treatment of choice. That is correct, and that's easy. So pulse steroid therapy is a treatment of choice. And actually, just to mention this in optic neuritis, normally we wouldn't want to give oral steroids after that. There's no evidence base that oral steroids are helpful after that, but we do give it till we get the rest of the results, because in other conditions, for example, neuromyelitis optica, they should continue on a high dose oral steroids for a better remission. So if it is part of another condition, sometimes we would keep the steroids a little bit longer till we get all our results. Do we have time to discuss the last case? I'll finish it too. We can start and then we can continue later. So, because I think last case is pretty good. So last but not least is another 15-year-old girl who came in with gradual bilateral lower limb weakness and no longer able to walk independently. This child was previously fit and well. When we looked at her history of present illness, she had fever and cough 6 weeks prior to the presentation. She was presenting with gradual lower limb weakness and cough pain, and it was affecting her mobility as well as her balance. So she was using a stick to help her walk. She was complaining of extreme fatigue, but there were no bladder bowel dysfunction. And she was also complaining of diplopia and blurred vision for around 2 weeks. So this was a previously well child. She has high functioning ASD, and she had a corrective squint surgery 2 years ago that was apparently unrelated to her current presentation. When we examined her, her upper limb power was normal. Her reflexes were present. Her lower limb power was a bit patchy, so her extensors and flexors, it was less, so 4 out of 5. But then hip abduction and adduction was around 3 out of 5. We couldn't elicit any lower limb reflexes, and she had downward going planters. When we tried to examine her gait, she had a foot drop bilaterally when she was walking. And as I said, she needed support for her walking, and she had normal sensation on crude testing. When the physiotherapist and occupational therapist came to assess her, they did something called the ASIA scale, which some of you might have used before. And they found on dermatomal testing that she had reduced sensation to pinprick, so to pain, on the left side of her, so of L4 and L5, and her light touch was reduced bilaterally on the dermatome of S1. I just thought for you who haven't used an ASIA scale before, I've used it only once on one of the children, so it's not very clear, but it's the American Spinal Injury Association, so it's an impairment scale that we use to assess pinprick and touch sensation and reflexes. So it's a dermatomal testing. So it's actually quite time consuming. You test each dermatome in your body, you give it a score. And the reason we do this so exhaustively, if you do it at the presentation and after giving treatment, you can see if there's recovery of sensation, if there's improvement. So it's a lot more accurate and better than crude testing in any condition that affects your spine. And this is how it looks like, the diagram. So you would have that pre and post. So they did that testing, and she did have some affection of her pain and light touch on some dermatomal testing. Investigations, we did an EMG and nerve conduction studies. She had affection of her axonal motor and sensory neuropathy. And when we did an MRI, her MRI brain was normal, and her MRI spine showed a conus and coda equina enhancement. I'm sure you all know by now what I'm talking about. So this is Guillain-Barre syndrome. So normally in your nerve, you would have the dendrites that collect your signals. The signals pass down that yellow bit, which is the axon, and this axon is covered by your myelin sheath. And then your signal is conducted to your muscle fibers through your neuromuscular junction. So in Guillain-Barre syndrome, we have it's a demyelinating condition. So as you can see in the other picture, your myelin is affected and is no longer able to conduct the signals in the peripheral nerve. So how did we manage our child? She was initially given IVIG in her local hospital events, but didn't really have a good effect. So she was also started on gabapentin, quite a high dose, because she was complaining of a lot of pain, so mainly was neuropathic pain. When she was transferred to us, we put a VASCAF insertion, which is a central line, and we started 5 cycles of plasma exchange to see if that will help her symptoms, and she had ongoing physiotherapy and occupational therapy input. Pre-discharge, she had improved power and improved walking. She was now walking unaided, so not needing support, and she had a better balance. She had an improved ASIA score when we repeated it post plasma exchange with dermatomal testing. Her pain was better, so she was able to tolerate her sessions better. We used a foot-up splint. I put a picture of it. Obviously, it's not her, but just to help her foot drop and also help her walking. And normally you would wear that and then you wear the shoe afterwards. And then she was having ongoing rehabilitation in the community. So Guillain-Barre syndrome, very quickly, because we only have 4 minutes left. So it's an acute inflammatory demyelinating process. The classic presentation of Guillain-Barre syndrome is you have an acute acute monophasic non-febrile post-infectious illness. Ascending weakness, so starts distally, goes proximally, and areflexia, so no reflexes when you test your lower limb, so it's progressive, ascending, flaccid paralysis. Guillain-Barre syndrome, it's actually it's the most common cause of acute motor paralysis in children. It used to be polymyelitis, but after immunization and after eradication, it is now the most common cause of an acute motor paralysis. There are many forms of Guillain-Barre syndrome. It could be in our girl's case, it was a motor and sensory axonal neuropathy. Sometimes it just affects the motor components, so it's a motor axonal neuropathy. Rarely it can just affect the sensory components, like a sensory neuropathy. And in some cases, we have something called a Miller-Fisher syndrome, which you probably know. Miller-Fisher syndrome is a triad of areflexia and ataxia, and you have ophthalmoplegia. and also another form where the ocular nerves are affected. So that is pretty much Guillain-Barré syndrome in a nutshell. Then if we continue, it's normally a preceding bacterial infection, such as Campylobacter, other viruses, such as cytomegalovirus, Epstein-Barr virus, Mycoplasma. Vaccination against flu, against meningitis, against rabies can also cause Guillain-Barré syndrome. The symptoms usually occur within 2 to 4 weeks from the trigger, but the recovery period is quite long, sometimes can take up to months. And it's fatal in 5 to 10% of our patients where they have respiratory failure and cardiac arrhythmia. So our pathogenesis, I'll try to explain it very briefly. As you can see, did this child have a lumbar puncture? No, did not have a lumbar puncture. Actually, might have had in a local, but not with us, not in our hospital. So pathogenesis, so this is the Campylobacter jejuni infection, someone who's had a diarrheal illness, not this child, but I'm just giving an example of predisposing factor. This triggers an immune response. So the immune response forms antibodies, and there's a cross-reactivity between, so the antibodies attack this infectious agent, but they also attack the GM1 cells in the nerve gangliosides. Causing, so they attach to the nerve and cause a nerve dysfunction, and this process is also mediated by macrophages. So you get this demyelination, and then the nerve is unable to conduct in the peripheral nerves, and then you get this flaccid paralysis. Sorry, I'm going a bit fast because we have only 1 minute left. In cases of Guillain-Barré syndrome, you would have a foot drop, you would have lower limb weakness, you would have areflexia, so absent reflexes, and in some severe cases, you would have a bulbar dysfunction, so affection of speech, affection of swallowing, and some autonomic manifestations. Most of them have some autonomic disturbances that then resolve. They can present with neuropathic pain, and in severe cases, as we mentioned, respiratory manifestations. The reason I put this slide is that it's really important with respiratory symptoms that we assess that clinically. So if there's any dyspnea with effort, shortness of breath, difficulty in swallowing, a change in their speech, and sometimes, as I said, they would need respiratory support, and there's a ventilation failure that's in a third of the patients. It's mainly a clinical diagnosis, but EMG and nerve conduction studies are helpful to confirm it. Normally, baseline bloods and metabolic testing are normal. If we do a lumbar puncture and a CSF analysis, you would have high levels of protein without an elevation in their white cells. So we call it an albuminocytologic dissociation. But as I said, it's mainly a clinical diagnosis. You don't need to do a lumbar puncture in each patient. Sometimes we do an MRI spine to exclude other causes that could be, for example, causing a compression or a mechanical myelopathy that can present in the same way with a lower motor neuron lesion. So in this condition, it was a lower motor neuron lesion, unlike ADEM, where it was an upper motor neuron lesion. So we can see examination is quite important. IVIG is helpful in reducing the severity of the disease and the duration of symptoms, but it does not affect the long-term outcome. Same for plasmapheresis, it decreases the severity and shortens the duration, and normally we give between 4 to 5 cycles of plex or plasma exchange. Steroids are not used. They provide little benefit as per current data. So we have our 3-question quiz, and then I will let you all go, and they're quite easy. So infection with which of the following is recognized as one of the most common risk factors for Guillain-Barré syndrome? E. coli, Toxoplasma, Campylobacter, and Listeria.
That's right, Campylobacter.
Perfect, that is correct. Which was in our pathogenesis, so it was easy. Which of the following regarding the presentation is accurate regarding the presentation? 8 weeks after respiratory GIT illness, bowel and bladder dysfunction are common and early. Most patients reach clinical function nadir by 4 weeks, and papilledema secondary to elevated intracranial pressure is common.
Number 1, they typically present 8 weeks after respiratory or GI illness.
I'm afraid that is incorrect. So, but that was a tricky question, so that's fine. So it normally actually occurs much less than that. So 2 to 4 weeks after respiratory or GIT illness. So it's a shorter duration after the prodrome or predisposing factors. Bowel to bladder dysfunction are not common and do not occur early. Most patients reach clinical, so they reach this plateau of their clinical symptoms by 4 weeks. Papilledema, secondary ICP, it is not common in Guillain-Barré syndrome. Last question, which of the following is accurate regarding management? Oral and IV steroids are commonly used as monotherapy. IVIG and plasma exchange hasten recovery. Evidence-based show that IVIG definitely affects long-term outcome. Blood gases are helpful in assessing neuromuscular respiratory failure. Perfect. That is correct. So IVIG and plasma exchange hasten recovery. However, they do not affect long-term outcome. We don't really use steroids. There are no evidence base for it. And blood gases is a very late sign. We always assess respiratory, we do respiratory assessment clinically by a peak flow, by pulmonary function tests, but blood gases would show, if you actually have an abnormal blood gas, that's a really worrying sign. Yes, that's a good point. Sorry, I didn't mention that. So you said the case of GS had a change of vision. How come? This was a red herring because she was complaining of diplopia and blurred vision at far, when she looks at far things, but not closely. And that's why we did an ophthalmology review. We thought she was having increased intracranial pressure. We did scans, but it turns out it was probably related to her old squint surgery that I had 2 weeks ago and was unrelated to this presentation. But she did give us a few days of testing and ophthalmology review because we weren't sure if something else was going on. And as I said, it was a very temperamental diplopia. We noticed a very minor squint, and the ophthalmology team were going to follow her up as an outpatient from a squint perspective, unrelated to her Guillain-Barré syndrome. So thank you, because I was going to mention that, because she did confuse us with that. Thank you. Does anyone have any more questions that I can answer and maybe post later because of time? I would really appreciate it if you can fill the feedback forms. That would be great. Thank you. Thank you.
Thank you.
Do I stop recording now? Yeah, I think I should. If you have any questions, there are a few questions I didn't answer and I wrote them down. If you have any more questions, just post them and I'll answer them later.